Good morning. Thanks for joining, everyone.
Great.
We will go ahead and get started in probably about 3 minutes, but while we wait for others to join, we would love it if you would share in the chat box your name, your organization, where you work, and what country, and one thing you've enjoyed while living through this global pandemic. Hopefully we can all come up with something. And in the meantime, we'll just give a couple of minutes for others to join. Hi, Sarah Jane. Hi, Joan. Hi, Abdul Mumin. Welcome. Thanks for joining. I see y'all are touching on, I think, some things many of us have enjoyed. Walking, being outside, not being in the car all the time. I see some more folks are joining. Good morning, good afternoon. Nice to see some familiar names on our participant list. Hope you are all doing well this morning and this afternoon. I think we'll just give one more minute. Okay, shall we go ahead and get started? So welcome. Great to hear from you all. Nice to have you with us today. This is our second quarterly meeting of the year of the Systematic Scale Up of Family Planning and Reproductive Health Best Practices Community of Practice. And you may scroll through the chat if you'd like. You can see perhaps some inspiration for things people have been enjoying this year during the pandemic. And I think we'll go ahead and get started. So Sarah, if you could just go on to the next slide, that would be great. I'll walk us through our agenda. So today we'll be, of course, introducing our panelists, and we will jump right in then to what we're calling a listening session. And during that time, Kirsten Krueger and I will be offering some questions for our panelists to answer before we jump into the Q&A portion of our meeting. And that's where our community of practice members will have the opportunity to dialogue with the panelists who are joining us. And then we will jump into a member tool feature, and we'll be looking at Spring Impact's Journey to Scale with Government tool. One small reminder is just to stay on mute unless you're trying to speak to the group. And with that, we can move on to the next slide. Great, so this is our small and mighty team at FHI 360 who convenes this community of practice. Trinity Zan is Associate Director of Research Utilization, and hopefully you will get to see she's been experimenting with very fun hair colors during the pandemic alongside her son. It's always really fun to see what color they're working on. Kirsten Krueger is a technical advisor in the Research Utilization Unit at FHI 360, and she has enjoyed not having to commute and walking around barefoot. My name's Sarah Brittingham. I'm a technical officer in the Research Utilization Unit, and for me, the pandemic brought the opportunity to move back to Durham, and I got myself a kayak that I have really enjoyed taking onto the Eno River here in North Carolina. Sarah Dixon is also a technical officer in research utilization, and she's enjoyed having Margot and Maggie, her American Bulldog and Beagle, as her coworkers. So these are the panelists that we intended to have for you today. It looks like we may have some last-minute shifts, so I am unsure how many will be able to join today, but we do have Dr. Obua on the line. I will go ahead though and introduce each of our panelists. So first, we are expecting Dr. Grace Codindo. She is a Chadian obstetrician who has championed improvements to reproductive health care not only in Chad, but throughout the world. Dr. Thomas Obua, who's with us today, is the senior pharmacist at the Ministry of Health in Uganda. Prior to joining the Ministry of Health, he worked at Butabika National Mental Referral Hospital and Lira Regional Referral Hospital. Next, Dr. Mohammed Rilwanu is a medical doctor and consultant, as well as a fellow of the West African College of Physicians in Public Health, and he currently serves as the executive chairman of Bauchi State Primary Healthcare Development Agency. And finally, we hope Dr. Claudette Diogo will be able to join. She's been called into an emergency meeting in Ghana. She works with the Ghana Health Service and is a pharmacist by profession. She's been responsible for ensuring adequate stocks and availability of SRH commodities in country and across all levels of the healthcare system as the logistics and supply manager. Great. So one thing we wanted to share with you is that this session today is very much community sourced. So thanks to those of you who contributed in one way or another. The idea for the session came from the discussion portion related to charting the way forward in our last meeting of the Community of Practice. And we actually sourced some of the questions that we have for our panelists today in a survey that we sent out to the listserv. And some of you even suggested panelists, which was great. So thank you to all for kind of helping pull this together. We've noticed this topic has actually gotten quite a bit of traction. In the past week or so, there have been at least 3, maybe 4 meetings that I've seen about government leadership in scale-up efforts. So I think it's really rising to the surface as a very much top-of-mind important issue. As I shared, we're calling this session a listening session, and Kirsten and I will be asking questions of our panelists. We just wanted to kind of point out that it's really not often that we have this type of opportunity for a more unstructured time with government colleagues, and with such deep expertise and experience, we're really excited to have those who were able to join with us today. We know that they are very, very busy and are very grateful for their time. It's quite generous to spend it with us today. And with that, I would like to go ahead and ask the first question, which I will pose to Dr. Obua. And that is, which areas of family planning and reproductive health are you prioritizing? And how do you prioritize for scale?
Thank you very much, colleagues. My name is, like it has been indicated, Obua Thomas. I'm a senior pharmacist. I think the basic area of family planning, for now, as a government, we think it is the community base. would help us, because family planning is a service where people get when they are not sick. And the practice in many of our African countries here is people only go to the health facility when they are sick. So if they are not sick, they don't come. We have to look for them. So our emphasis is actually looking at the providing family planning services to the community. We may not completely finish the community aspect of it, but the health system in the country ranges from community health system, which is village health team. Then you come to level 2, health center 2, health center 3. These are basically in the countryside, but we have also moved further to get to the service drug outlet in the countryside, where actually these people live in the community. So the most important thing we are actually emphasizing on reaching the community with the services. In the hospital setup, the health facility setup, it is there static, yes, but we almost came to a standstill. We were not improving, so we had to look at the alternative distribution system, where we thought we have tried the normal system. We are not doing very well. What are the other systems? So these other systems, trying to look for where people always get in the evening, get during the day, have their free time. We then have to relocate some of these family planning commodities to these outlets, and we seem to have moved on. Thank you.
Thank you, Dr. Obua. I have a couple of follow-up questions.
Yes.
That which is useful. I think we're, unfortunately, we're missing currently our other panelists. So we're a bit surprised, but we're gonna roll with it. And the good news is that we get to go very in depth with you. So I hope you're prepared to share a lot about your experience. So just as a follow-up, I heard you say that community-based FP services is a priority right now. And in terms of the process for scaling up such practices, such a service, I'm interested, this was a question that we had, I think this one came from somebody in our COP group, but what kinds of mechanisms, personnel, processes does the government currently have that assist with scale up, or the mission is to assist with scaling up interventions?
Oh, yes. As a government, there are several other things which should be put in place so that these services can reach people. Number one is to set the working environment. And setting the working environment means putting policies, putting guidelines, relaxing some of the strict laws for handling of pharmaceutical products. And that if that one is done, which we have done, we then go ahead to look for the people who should help us perform this task. And here in Uganda, we have very good environment for civil society organization, where a number of them in health service areas and the family planning, mother-child health being a global impact indicators. Many of these colleagues of ours come on board. We support from development partners, and they're given a little resources. We retool their thinking, because when they're writing their proposal, they write in response to the expression of interest which has been asked. When they are done, then we can come and retool the thinking. They understand the context. If this is now understood, then they go ahead and recruit. We have so many people trained in the country. There are so many health training institutions in the country. So we have these people, many. And also in our universities, we are providing public health training to people who did humanity courses in the universities. So they come and do at a higher degree level, at a master's level, they do public health. And in this public health, many of them try to major on the community aspect of life and then the quality of life of people. And looking at this, the quality of life, you are talking about controlling the population, and then you can only control the population, the quality one, when you are providing family planning services, reproductive health services. So all these things have been put in place. And then also I was talking about the distribution system, where the normal government system was not performing very well, particularly in family planning, community reaching the people. So we had to put in a system of alternative distribution system, which when we use this thing, it has helped us to move. So the system is there, the environment is there, the civil society organization is there, community-based organizations are there, and development partners supporting this colleague of ours to perform their tasks. When we pull these resources and then the infrastructure available together, we have been able to do a lot in this area. And I want to confirm that here in Uganda, we work as a team and we work together. There is nobody who takes the lead. We in the sector, we guide, and then the work, we do it together, and then we seem to have moved. Thank you.
Thanks so much, Dr. Obua, for that. I feel like you really drew on the kind of broad base of stakeholders and the government's role kind of leading and convening and kind of drawing information from various parties, which feels like an important piece. We know that you were, very involved in the rollout of DMPA in drug shops, and would love to hear more specifically about your experience with that. So one question would be, if you could speak a little bit to the road to policy change that really made space and allowed injections by drug shop operators. What were the key activities that led to that, and what can you share about that process?
Yeah, I think many of us live under the environment of the British laws. And the England law, which was left with us, the Pharmacy and Drugs Act of 1970, put all the injectable at the level B, the class B, and all the class B medicines, including injectables, are supposed to be provided by a doctor, pharmacist, dental surgeon, and veterinary surgeon. And to some extent, midwives. So it was then becoming very difficult to access people with these services. What we did, we had to put a case to the top management of Ministry of Health and brought out the realities of what the law says and then of what should be done to meet the realities. So when we did this through the support from PATH, which is very renowned in his researches, they got some authority. We gave them authority through our National Drug Authority. They went and did the study. They gave the report. We used the report to get approval from Ministry of Health and National Drug Authority. Then after that one, we were able to assemble a few of these districts with the drug shop. National Drug Authority gave us the criteria for choosing the drug shops. And then at the end of the day, we got these people, brought them together, retooled our training to meet the level of the people who should be the owners of this drug shop and then the technical person who are employed to do the work. We put them together in the same class. We talked for about a week or so. We understood them, they understood us. And in the end of the day, we were able to reach out with the commodity which we wanted to give to these people. So we did this study after about 2-3 years. It has now been fully approved by the National Drug Authority and Ministry of Health that these services should now be scaled up in the countryside. But we thought we would move on a phase-by-phase method of work. We didn't want to overwhelm ourselves, and then in the end of the day, we failed during the course of the work. We want to go step by step until we cover the country. And the criteria is the district is willing to support the work, so that we can start. They then take over, they give stewardship, we support them with whatever knowledge they need, and then the environment of the legal environment will relax. But the National Drug Authority still takes the lead in the legal environment so that people don't misuse these commodities. And I think we have moved. And I want to say that I'm proud of this kind of thing, because we have to put a very serious, strong argument to relax this regulation and laws, so that we have these commodities reaching the people who need them, who actually stay in the community, not in the urban centers. Thank you.
Great. It's great to hear and be reminded about the DMPA injectables in drug shops and pharmacies. I had the pleasure of working on the precursor community-based access to injectables through community health workers, initially with the intramuscular injection, later with the subcutaneous, and all of that leading into the drug shops and pharmacies work that I know FHI had a lot to do with the initial research and evidence around that. So it's a pleasure to be reminded and to see how far we've come in that regard.
Actually, to put more a bit of a correction, it's actually FHI which co-facilitated this study, and together with PATH, we were able to break all the bridges, to break the dams, and then we created the bridges between the policymakers, the regulators, and then the service provider at the country level, community level, so that we had to have this thing succeed, and indeed it has succeeded.
Excellent, yeah. Super. So digging into that a little bit more, I mean, we know that for an intervention to scale up on a big scale in a country or a region, of course, lots of resources are needed for such growth. But within the government, are there, I mean, from your perspective, are there individuals or designated units or bodies of organizations that do some of the work of scaling up? If you took away the resources element, you know, what is available, or what do you need to help get to widespread scale?
Yeah, I think what is very available disregarding the resources is actually the skilled human being, which I have told you. There are so many health training institutions in the country. The training has been liberalized, although regulation is done by the medical professional councils. That we have 4 of them: the nurses, the pharmacists, the doctors, and allied health professionals. So they oversee the training, and then they give the standards. So those people are there. 2, the community has been well sensitized on the dividends of the National Health Survey, National Health Demographic Survey, and the dividend about the quality population, quality citizen. What do I say? The people who know what they need to make sure they are healthy. The community now is aware, and many times now they are asking for these services. That's one. Then the third one is, like I told you, when we go with the implementing partner, development partners, and we reach the community, the district leadership, we tell them, we are starting, we are giving you these skills, we are giving you this knowledge, we are giving you these strategies. After we are gone, how are we going to sustain this one? So every district comes out with these sustainability programs, And at the end of the day, the cost of these services gets down, particularly when we have already our VHT, village health team. These people, they don't need any salary, but they are always supported very little with SDA and maybe transport within the community, not much. So all these things has made the work a little easy. And I think money put aside, if there is a good thinking in a human being, the level of knowing what you want to achieve, you can still always go ahead and do the work with minimal support for money. Of course, money makes work done, but if you cannot work, then what is money coming to do? So those are some of the philosophies we use, and then make our communication well taken, and thereafter we see work being done. And the good thing is that when you are done, you see people now asking, we need this service, we need this service. Then they will give it back to you and say, yes, you need the service. Are you able to continue with the service when we have brought it? Say, yes, yes, we can do. So that has made us really move. And we thought it is a good idea to pick, so that we leave the responsibility of health to the community, to the person who needs the health. They should ask, we give them the answer. And because of that one, we have been able to move.
That's great. I'm curious, I hear that Dr. Rilwanu has joined us. I'm wondering if you might like to speak a little bit to this question about resources for guiding Scale Up, and hopefully you were able to hear Dr. Obua's comments.
I'm just joining you. I was trying to join you, I couldn't join. And my name is Dr. Rilwanu Mohammed. My question is, in your experience, what catalyzed scale-up effort do we have in Nigeria and state? So are you hearing me now?
Yes, loud and clear, thank you.
Yeah, well, what happened is that there's a government commitment to quality of life of the citizens in Bauchi State and Nigeria. There's increased demand of family planning service in the state. And there's partnership and teamwork going on. Increased evidence for program success. Budget line for family planning and releases are there in Bauchi State as well. Since this government started, cost-effective approach to family planning intervention and learn from TCI. TCI has been the vanguard that put us through technically. With availability of enabling policy like TST, SSSDP, CIP, we are better off. And in coordination in Bauchi State, we have PSC working group, which actually carry out all working. I'm the chairman of PSC working group. Then we have service delivery working group, MIE working group, training working group, community engagement and social mobilization working group, mentor for family planning and master trainers. I'm a mentor of family planning, and we also have master trainer. That is enough to say that these are the efforts that can be used to scale up effort in Bauchi State. That is the thing that we are doing. We have an MOU, Bauchi is one of the 6 states that is having MOU. All this working group, I'm the chairman of this working group. And then we also have data and monitoring working, which is key. Then the second question, do go for the second question again?
Let's see if Dr. Obua might like to speak to that question about what catalyzes scale-up efforts. And then we could move to the next question. That would be great. Okay.
The next question you said was, what resources do government need in order to successfully scale their site funding?
Yes.
Number one is train and motivated human resources. Number 2, uninterrupted commodity and consumable supplies. What happened is that during the COVID-19 time, we have a lockdown, whether partial or complete lockdown. There was absence of long-acting contraceptive. Most of our women and fathers, they like these long-acting family contraceptives, and at the end of the day, there was a commodity that was not available. So because of the lockdown, could not get those commodities. Even transporting from Abuja to Bauchi and other places were not available. So that has caused a lot of interrupted commodity supply, and they don't even buy it. It's free commodity. We don't sell, and it's government and partners that join to give. The enabling environment for service delivery is another one. Second one is the equipment. We have all necessary equipment in Bauchi State to carry out our activity. Particularly the TCI was able to scale up activity in most of our facilities, making sure that there is 72-hour makeover. Our family planning uptake has increased just to almost 80% in Bauchi State. And then the male participation and traditional rulers and religious leaders are speaking about, for example, family planning in their own mosques and churches during the services and during Juma prayer. That has helped us a lot in the uptake of services and child spacing. Then we have skill, technologies, and other effective partnership and teamwork. We are working together with all other partners, Ministry of Health, in the State, Federal Ministry of Health, State Ministry of Health. All our partners are joined together to have a teamwork so that we can go in and be better.
Thank you, Dr. Rilwanu. We will be moving into a Q&A session shortly, but I did want to pose another question. Question to Dr. Thomas Obua. Dr. Obua, we were interested in hearing from you. Given your audience today, primarily implementing partners on this call right now, what kind of advice do you have for us, or what would you like for us to know about scaling up with government?
Okay, well, I would want to say that in scaling up, we need to move together as a team, like my colleague from Nigeria said. We need to move together as a team, government, community, and partners, so that we move as a unit, so that the information being given to the community is the same information from everybody. So that one will make the scaling up become very easy. Two, like I said, the environment of work. Yes, there could be some laws and regulations which make life very difficult for people who are working, because sometimes they feel timid because they seem to be breaking the laws. But when some of these laws, like I said, government is responsible for the life of the citizens. So whatever government comes out to pronounce on, it should be able to facilitate people to offer the services. So if the environment of work is good, then the scale up becomes very easy. And then the other one, of course, we talk about resources, yes, but to me, the most important resources is actually the commodities. Like my colleague has said, if the commodities are there, these are resources of transporting from here to there. Is people will always look around and then get what to offer to the community. And then, of course, the local community, particularly the male involvement is key, because many of these reproductive health services, family planning for that matter, is people seem to think that it is for female, and therefore males seem to get to the rear of it. But at the end of the day, they are the one that cause a lot of issues. So usually when you bring the male participation in the forefront, then it becomes very easy to achieve the scale up. Then the other one, the community leaders, opinion leaders within the community. Those ones are very important. Say religious leaders, say clan and tribal leaders. These ones, the statement they give is always taken by the what? By the subject. So when all these things are put together, we should be able to move on. The only issue which we have been having is our partners, particularly you said, is the brand, the private brand. Or usually when they support us and we try to give it to the private hands, and sometimes, you know, human beings always want to exploit any gap. So sometimes it ends up by being sold. So it has always been a challenge but I think in a meeting in Abidjan, is it Abidjan in Senegal, Dakar, we were promised that by 2022, next year, we should be having the brand from FISA, which is meant for the private sector. So that it makes us not to begin mixing things and begin explaining here and there. So when all this environment are put together, the scaling up is very easy. We already have the approval from the National Drug Authority, the approval from the ministry. Therefore, it is very easy now for people to be asked to provide the services. And sometimes this drug shop within the community, by offering these services to them, you get many more people to come and get services from you, and in the end you get something out of it. So all these things as the benefits to both the government for offering services to improve the quality of life, but also the people who are providing services also end up by getting clients, and in the end the work is done. The male partners, they are always difficult, but sometimes when you put them down and talk with them, they become champions, and then work, the scale up will become easier and easier to achieve. So those are some of the areas I would offer. Thank you.
Thank you so much, Dr. Thomas. This is Trinity from FHI coming in. So thank you to both Dr. Thomas and Dr. Rilwanu. Those were really excellent comments, and actually a lot of similarity in your responses, which is really nice to hear as well, although you have different experiences. We'd really like to take some time now to allow our participants to ask direct questions to our two distinguished guests, and we have a few different ways you can do that, whatever you're most comfortable with. We're a fairly small group, so if you'd like, you can just unmute and pose a question. There's also a raise a hand function at the bottom of your screen. If you see the reactions button and click on that, you'll see an option for raise a hand, and I'll look for that. Or you can type your question into the chat box. So whatever you're most comfortable with, but we invite you to take advantage of this opportunity to ask whatever questions you may have to our two colleagues. So the floor is open. Any questions? You can put it into the chat, raise your hand. I don't see any hands raised yet, or just come off of mute and feel free to ask. If not, I have a question in my, oh, fantastic. I see a question from Laura for Dr. Mohammed. It seems like TCI is assisting you in your work. How would you describe the TCI approach as being different from the way other partners have worked with you in the past? That's a great question. So Dr. Rilwanu, over to you.
Thank you very much for this question. TCI was the first organization in the whole country that started with 72-hour makeover. And then when they came in and they brought us together as a team. And so they have a team approach to their work. They make us to understand that we need to put family planning commodities in our budget. And we need to also look for release. So we join hands with the Ministry of Budget and Planning to make sure that we have a sustained budget and release every year. And then concerning the 72-hour makeover, by the time they came in, they started doing on their own. They did 25 in Bauchi State, 72-hour makeover. And that, what they're doing during the 72-hour makeover is that they have what we call quality improvement team. This quality improvement team are the one that actually are the mangoers or people living in the environment, the in charge, and other people that are very important and influential. They are the one that decide where to site the child spacing or family planning unit, and where the door will look like left or right. And then with the engineers, we now look at the thing and see that it is okay with the rent commitment will not affect. So I was so happy because from the planning, implementation and evaluation of the TCI program, it starts with us. When it starts with us and then we are together doing it, so we now copy from them. We have done almost six 72-hour makeover as of today. In Bauchi State, we have got approval of 12. We are able to do 6. And then this year, I sought for approval of 3. We got the approval from the governor. We are going to carry out 3. Now the TCI has almost left because they are now scaling up to the other side of the Gombe State. But we are still asking them to come for technical support, both technical and talk about, we don't even need the financial support. We really need that technical support. When the commodities are always available, TCI make sure that those commodities that we have in out of stock, like long-acting family contraceptive, it is there that our women now are not having given birth immediately when they are breastfeeding. They supply those progesterone-only pills to all the facilities so that women will not be having multiple pregnancies before the next, so that will have exclusive breastfeeding. And they encourage that. And then there is male involvement. They involve all the emirs were involved in the crusade of making sure that family planning uptake is increased. The traditional rulers, our religious group, TCI itself, when they were going, if I have the way, I would have said that TCI should not leave Bauchi State. It's one of the organizations that give us technical support in our working group, as I mentioned. Those government PSC working group that we have, they are the highest technical supply of information. So we really we are happy about TCI, and we actually emulate a lot of things, and we got a lot of things from them.
Great. Thank you. So that was a lot. I think we're hearing a lot about the approach to teamwork, about taking particular interventions, what might be a 72-hour makeover that may have started prior to that with a previous project as a 24-hour makeover, per a comment from one of our participants, Dr. Saad, and identifying priorities focused on commodities. So that's really interesting. Thank you. Would others like to ask questions to Dr. Rowanu or Dr. Thomas? Again, you can put them into the box, can raise your hand, or you can just feel free to unmute since we aren't too many people. I may take a privilege of a pause and ask a question, but please, if anyone does have questions, go ahead and raise your hand or put them in the chat, and then we can get to those next. I wondered if either of you, Dr. Rowanu or Dr. Obua, do you have an example of something that you thought was going to scale but did not scale ultimately? So something that you really thought was great and it was going to go to scale, and then it didn't for some reason. I wonder if you have an example of that, and if you do, if you have any thoughts on why it did not scale. So either of you could go. Maybe let's see if we can hear from Dr. Obua first, since we just heard from you, Dr. Rowanu. Dr. Obua, do you have an example like that? You may still be.
I don't know that, but what we actually tried to start, and indeed it failed because of some other issues, was we had as a department, I mean as a sector, Ministry of Health, we thought we were going to scale up this community health concept of the Ethiopia, where we were going to get at least 2 fairly trained community persons, put them in every parish, 2 of them, so that a few villages get some technical advice from them. After we have done everything, and then now we're remaining is selecting people to come and train. In fact, it was even done in a few of the districts, but when it came to implementation, it failed to take up. And when we begin asking questions, we could not get the answer. That's the only, because if we had these community people now fairly trained and coordinating the village health people who are actually selected from the community, it would be able to improve even the quality of these services within the community, but it never took off. And
that's really interesting, Dr. Obua. You said you started asking questions about why not. So to whom were you asking those questions, and did you get any answers, or do you have your own hypothesis about why that didn't move forward? Was it simply a resource question?
This is something we ask ourselves. Because you may want to ask the higher level of decision makers, and they would tell you have not done a good job. But we ask ourselves, where did we go wrong? And then I thought, I think at our thinking as technical team, we thought our method was the best. But when we went to strategic level decision making, our decision was somehow found to be wanting. And until then, we have been asked to go back to the drawing table. But the energy now and the motivation to go back to that table is still being built up. And I think it has taken close to 2 years now. It is not building up. But it was really a work well done. And I think we just failed to get the better strategy of implementing it from the strategic level and to the technical level. That one was very painful because we took close to 2 years to develop this document, but in the end, we got nothing out of it. It was very painful, but we have learned to live with it positively, like we did with HIV/AIDS.
Well, I really appreciate you sharing that experience, because it's not easy when we feel like something we were planning for and hopeful for didn't work out. And I think what you just shared is that sometimes we may prepare our case and yet it may still not resonate with the highest level decision maker. And so that aspect of engaging at the high levels of trying to determine what will be convincing is a really big part of the scale up process. And yet, as we often say, there's a science and an art. And particularly in that kind of policy advocacy realm, I think there's a lot on that art side, and a lot of it is luck and chance. So
I think actually what we call implementation science was the one that failed us. Because the art is there, the science is there, but how to implement these two?
No, well, that's so important. What an important insight, that really what we need is more information on the how. It sounds like that's what you're saying. You needed more on the how so that we could better prove that process and perhaps then, make the case to the higher ups. Very interesting. Thank you so much for that. Dr. Rilwanu, please go.
Yes, there's one thing that I know that we wanted to scale up. We have 1,300 primary care centers in Bauchi State, Nigeria. And then we have all the PSC per ward for political ward, we have 323. All of them, we have family planning centers where we carry out family planning services. But we want to scale up to the clinics where we have about 648. Because of human resource, we cannot scale up. That is our problem. We cannot scale up to 648 centers, which are also part of the world, but there are so many because of human resources. That is the reason why we cannot scale up those areas. That's the biggest challenge we are facing now, human resource, to carry out the work. All the other staff in the 323 PSC per ward, we have family planning unit where we carry out our activity. And women are going there they were happy, but people in Bauchi said happy with the family planning services. Women are enjoying it. The husbands are happy with it because of the service are free. I don't know when we started putting money, then maybe that will be the time they will say they wouldn't like to. But I don't know, they're happy because most of them initially think that the family planning services were meant to depopulate Africa. They now realize that family planning was to save life. All the maternal mortality, child mortality that was occurring will be reduced if we accept family planning. And most of the uptake of services and the delivery of services of family planning is being done in Nigeria, and people are happy. And what I'm so happy about is the Malams that were against family planning services and child spacing are now preaching in the mosques, in the churches during the service. So that has actually helped us to scale up. But to scale up to primary care centers, 648 centers, that is our challenge now. And then some of our partners like the TCI, the project has closed up this year. So we are just trying to use other organizations. Initially, Nuri was an organization that started about the 72-hour makeover, but they did not make impact. The one that we know that make impact is the TCI, because it is holistic, it is a teamwork, government are involved, we are together, and we're working together. Thank you very much.
Great. Thank you, Dr. Rulwanu. I'm sure our participants, like I, could think of many more follow-up questions, but I think we need to wrap up this portion of the session now. Thank you very much, Dr. Rulwanu and Dr. Obua. This has been very, very interesting. Thank you for taking the time out of your busy schedules. Of course, we invite you to stay with us for this last segment of the meeting today. So now I'd like to introduce Nora Dettor and Karen Lamb, both consultants working with Spring Impact, who are going to tell us about a tool that they have developed and that I'm sure we will all find very interesting. So they're going to share their screen, so give us just a second while we do that, and over to you both.
Thank you very much. I will hand right over to Karen, who will take us through that presentation.
Great, thanks Trinity. Hi everyone. It's really great to be here today. Like Trinity said, I'm Karen, Senior Consultant at Spring Impact, and I'm joined by our Managing Consultant Nora, who just introduced me. So a bit about Spring Impact for those who are not familiar with us. We are a nonprofit started out of frustration that there are so many ideas that could solve vital problems in society, yet these solutions often struggle to scale up and reach more people. And in our 10 years, we've worked with over 250 organizations in over 50 countries worldwide, and this includes supporting multiple stakeholders to scale their impact with and through the public sector. So the tool that we are sharing today has come from a partnership with Village Reach, and supported by a coalition of funders. We co-established a learning network to share best practices for working with government to own and scale a solution or innovation. And this is really because while many social impact organizations and funders aim to collaborate with government and work towards government ownership of solutions, there are not a lot of cases or examples where this has been successful. This may be because despite the best of intentions, government perspectives were diluted or lost, leading to government not feeling like they have ownership of the solution. Social impact organizations may exit due to shifting donor strategies or changing political climates. And another reason might be that all stakeholders or partners kind of lack a clear shared roadmap for the kind of long journey to scale ahead of them. So to meet these challenges and to support those who want to scale up their solutions through the public sector, through government, we co-developed the Journey to Scale with Government tool, as you can see on the slide, with over 50 contributors, including people from governments, social impact organizations, and funders from 16 different countries. This tool also highlights the mindsets, systems, and capacities required to work in a collaborative partnership with government and navigate the journey to scale together. So in terms of how to use the tool, it is not sector or location specific. We really wanted to encourage learnings to be shared across sectors. It is intentionally designed to be high level. It presents information in quite a digestible and memorable way. For example, the tool has a set of key questions to enable users to define and co-develop their answers together. It's also designed to be used by a coalition of stakeholders because the aim of this tool is really to bring all key stakeholders and partners together to align on the approach and expectations of really how to work together to scale a solution. And finally, it's possible to use the tool in a variety of different ways depending on your context. So for example, you can use it as a conversation starter with potential partners. You can use it as a workshop agenda or a framework to assess your scale plans. So at this point, I just wanted to briefly share some key insights around fostering strong partnerships with government from our discussions with the contributors of the tool, reflecting on their journeys to scale. And these themes are really the kind of principles that underlie the tool and the design of the tool. So first, really important is to embrace to center the voices of government. So really this is about taking an intentional approach to building government ownership from the very beginning of the partnership. This includes aligning with government priorities and expectations from the beginning, but also throughout. Second is to embrace radical collaboration. This is really about recognizing that no one actor can scale and sustain a solution in isolation. And really all partners need to embrace radical collaboration, act like a unit, right? Which will really require partners to go beyond self-interest and may require working in a different way. And finally, being a good partner takes serious commitment. They don't just happen, but if done right, the results are worth it. So based on these key insights from the Journey tool co-development, I'm just going to go back one slide actually. Spring Impact and Village Reach co-developed and facilitated a series of workshops to put the Journey tool into practice, also kind of responding to that point around the need for radical collaboration, which may require partners to work and think in a different way. And really the reason why we felt it was important to put the Journey tool into practice and to facilitate these workshops is because tools and concepts will only get you so far, right? Especially because most people can agree or can get behind working in partnership and can acknowledge that collaborating is important. But in reality, this is often easier said than done. So these workshops really aim to bring social impact organizations, governments, and funder partners that are on their journey to scale or planning their journey together to really give them a space and opportunity to reflect on their partnership. And really through this experience to strengthen their partnership by co-developing and reflecting on how they can individually shift their mindsets or ways of working to work towards a more collaborative partnership and really put that concept of radical collaboration into practice going forward. And Spring Impact, as the facilitators of these workshops, we used different facilitation techniques to support the participants to view their partnership in a different light. So for example, role-playing each other's roles to build an understanding and empathize with other partners' perspectives, imagining the failure of the scale efforts to allow partners to identify risks and voice concerns, and finally putting their learnings into practice by co-creating an action plan to strengthen their partnership going forward and committing to this. So to wrap up, we recently organized and delivered a webinar to further share these insights and learnings from the workshops and also from the co-development of the tool. So the webinar featured the BOMA Project, a social impact organization, and their government partners from the county government of Marsabit in Kenya, who both attended the workshops and are currently putting their learnings from the workshop into practice, and are working together to scale a poverty graduation program to achieve their common goal of empowering marginalized groups through economic initiatives that are government-led in the Marsabit region in Kenya. So if you do want to learn more from their experience, check out the webinar recording, and my colleague has just, I think, shared that in the chat, so do check it out. And finally, if you finally, to share some opportunities to learn more, we'd love to continue the conversation with you. So do email us if you have any questions or curious to find out how the Mindset Shift kind of workshops, the collaborative workshops, can help your organization. Do get in touch with us. And finally, if you're interested in learning more about the tool, do go ahead and download that. The link is in the chat as well, and join the Learning Network to keep up to date with all the recent news around scaling with government. So that's it from me today. Thank you so much for having us.
Wonderful. Thank you, Karen and Nora. Really appreciate you highlighting where you all have come with that tool since we last heard from you. So we're going to end now, and I'll just remind you all, if you're not already a member, to please become a member of the Scale Up COP. Also, our next partner meeting will be probably August next quarter, and we will share both the recording and slides after today. Thank you so much to all of our presenters. Thanks for your time, everyone.
Thanks, everyone. Be well.
Thank you, and a good night and a good day.
Thank you, Dr. Oboa.
For us, we are going to sleep. For you, you are still in the
Have a nice evening.
Okay, thank you
very much. Bye-bye.
Bye. Good.